Hi, my name is Zain Haj Ali, and I'm here with Daniel Kirolos and Yasmina Solidoso to present our work titled Multimodal Registration Techniques for Non-Contact Neonatal Patient Monitoring. Critical care for newborns admitted to the Neonatal Intensive Care Unit, or NICU, requires continuous monitoring of vital signs. Using an RGB-D camera placed above the patient and a pressure-sensitive mat, or PSM, below, we are presented with three different data sources that capture different aspects of the scene: RGB video, depth video, and pressure data. The use of these modalities in conjunction with one another can reveal scene information that can't be derived from studying one data source alone. For this purpose, we demonstrate a few registration techniques to align or otherwise combine the data from multiple sources and quantify the error of the registration techniques. Data registration across multiple modalities is particularly useful to overcome challenges often observed in the NICU. For instance, during periods of low light conditions, the patient cannot be easily seen in the RGB image. However, the PSM can still capture consistent pressure data. The depth stream using infrared technologies is also robust to this lighting variation. Therefore, the depth data can inform on bed occupancy, and depth alignment can further detect the outline of the patient in the bed. Other challenges might only affect the PSM. For example, if the patient's weight is too low to capture enough pressure data, or if the patient's limbs are moving freely and not creating enough pressure on the mat, the RGB and depth data can be used instead, as they would be robust to these issues. Multimodal registration aims to overcome vision-based and pressure-based challenges during neonatal patient monitoring by combining multiple modalities to compensate for one another in case one of them fails. Up to 6 hours of RGB video, depth video, and PSM recordings from 33 neonatal patients were collected from the NICU of the Children's Hospital of Eastern Ontario. The RGB-D cameras were placed above the patient's bed, whether it's an incubator, crib, or overhead warmer, often at an unspecified angle. A pressure-sensitive mat was placed under each patient, sometimes covered by a blanket or quilt.
To analyze both PSM and video data simultaneously, these data streams need to be spatially aligned through multimodal registration. This type of registration requires manual detection of distinct landmarks within the patient scene. These landmarks must be identifiable in both the video and PSM streams. In order to create these landmarks, we use a high visibility instrument, which in this case is a colored pen, and we use this to apply pressure at distinct locations on the PSM. This way, we gather points that are visible in the video and pressure points that are visible in the PSM. Once we gather these landmarks, which are visible in both PSM and video, we can calculate something called a registration. This is possible through linear geometric transformations. There are three main types of these transformations. The first is a projective transform. These are useful as they account for the perspective distortion. In the context of a PSM and video registration, if the camera image plane is not strictly parallel to the PSM, so the camera is at an angle, it will cause a perspective distortion, and this must be accounted for. However, it requires a minimum of 4 points to calculate. On the other hand, for an affine transformation, it only requires a minimum of 3 landmarks, and for a similarity transform, it only requires a minimum of 2. However, these transforms cannot account for this perspective distortion caused by an angled camera. The effect of camera position and transform type on registration error was determined through some experimentation, and it was found that in a top view setting, the similarity transform is preferred, while from an angled view, the projective transform is preferred, as it can account for the perspective distortion. Shown here are two examples of aligned PSM and video streams. As you can see, the pressure points correspond to different areas of the patient's body. This is useful in different settings. For example, our lab previously developed methods for estimating respiration rate of neonates from the pressure signal obtained from the PSM. So by fusing PSM and video data, we can obtain accurate segmentation in the PSM by transferring the areas of interest found in the video to the PSM. By locating the chest, we can then improve the quality of this type of respiration rate estimation.
Both RGB and depth images carry a lot of information about the scene and can be complementary during vision-based challenges, such as occlusions or lighting variations. We therefore investigated the fusion of both streams, but before doing so, these streams had to be aligned to the same spatial resolution. As you can see in both images, the depth image has a wider field of view, which captured more area of the bed and the bars from the crib. A transform function provided by Intel was therefore used to align the depth image to the RGB spatial image resolution. Once both images are aligned to the same resolution, we can perform RGB-D fusion so that in one image, both RGB and depth information are included. To investigate the effectiveness of RGB-D fusion, we explored several fusion schemes in multiple classification tasks to analyze the NICU scene. Several deep learning models were trained where in panel A, we first independently used the RGB and depth images as input. Then in panel B, we used two different image fusion techniques where the depth data is either concatenated with the RGB data or imputed as a composite of RGB data to scale it by the depth distances. Finally, in panel C, both RGB and depth data were leveraged directly into the network at different layers.
On some patient recordings, we can see that the bed's depth does not appear to be uniform, since the cameras were not all placed directly above the patient facing downwards. To correct this, 3 non-collinear points on the bed that are assumed to be on the same plane are used to find a rotation matrix. Each pixel in the depth frame is deprojected into a point cloud using their positions in the scene, their depth away from the camera, and the camera's intrinsic matrix. The rotation matrix is calculated by finding the normal vector of the plane of the 3 points and solving for a rotation that transforms it to be facing the camera head-on. The point cloud is then rotated using the same rotation matrix before being projected back into the array of depth pixels to be displayed. Since this will result in a frame with some information missing, we then apply a dilation using a small kernel. We can see here the RGB video on the left, the unaltered depth data in the middle, and the transformed depth data on the right. Taking a look at the views on the left and in the middle, we can see that when filtering out video data by using a minimum depth threshold as seen in the figure above, as we reduce the threshold, the patient's upper body starts to disappear before their lower body, and one side of the bed seems to be much lower than the other. After applying the perspective transformation on the data, we can see that the bed around the patient starts to disappear more uniformly, and the patient's head and torso appear to be directly below the camera facing the lens head-on. This concludes our presentation for today. Thank you for listening.